This episode of the Seniors Flourish podcast is brought to you by the Learning Lab membership, because I get it. I was working with older adults in home health when I started out, and I was the only OT practitioner. I was new, I had no mentorship, I struggled with the little things at work, and I was so incredibly overwhelmed. I was struggling to keep up with that paperwork, and because I was working such ridiculously long hours, trying to research best practice, find all the patient handouts I needed, I just couldn't keep up with it all. And the worst part is I was constantly doubting myself. Am I really doing what's best for my new patients? That's why I created the Learning Lab, because I desperately needed a way to get organized and have everything I needed at my fingertips. So it's cheaper than a textbook, but it has hundreds of treatment idea videos, patient handouts, evidence-based resources, and more right at your fingertips when you need it. So join today at seniorsflourish.com/Learning Lab.
Welcome to the Seniors Flourish podcast, where it's all about helping occupational therapy practitioners disrupt the norm by throwing away the rainbow art and being the best you can be when working with older adults.
Welcome everyone to the Seniors Flourish podcast. My name is Mandy Chamberlain. I'm an occupational therapist, and on this show, we like to talk about everything relating to occupational therapy and specifically working with older adults, because there's a lot of us out there working with older adults. And today we are going to be talking about repetition, and intensity for task-based practice to increase motor function after stroke. So I'm excited to have Lauren Sheehan and Lauren Souders. They're both occupational therapists, and they are going to share the research and how we can integrate this into our everyday practice and give us some tips and ideas on how to do that. So welcome, ladies. I'm glad you're here. It's like a little trio here today.
Good morning.
Hello. We're excited to join you.
Thanks. So let's just kind of get started. And before we jump into this topic, which I love because I've always had a heart for working with people who have had a stroke, because that's how I got into OT. Is my own grandfather had a stroke. And so some of my favorite things, talking about people who've had a stroke, the research, and what we can do about it. So let's start with I was going to say, Lauren, why don't you start? But since you're both Lauren Sheehan, why don't you start and just kind of talk about your OT journey?
Sure. Well, I came on kind of the OT scene, also really interested in neuro-based practice. Had a friend growing up that sustained a spinal cord injury, and then ended up doing some volunteer work with him. But fast forward, through the last 10 years of my career, most of it has been focused on neuro-based outpatient practice. I've spent some time in administration and management, so working on the business side of therapy, and then kind of came full circle about 2 years ago, left what most would call traditional practice for a job on the industry side. So I've been working for rehab technology companies, previously Neofect, and spent some time with you, Mandy, on a previous podcast. Yeah. And then most recently came on board with a company called Neurolutions. And so have really enjoyed applying neuro-based practice in the clinic and all my work with patients over the years with strokes, brain injuries, primarily, to now trying to figure out and solve this issue of how do we increase intensity and what are some options for really getting people the home-based practice that they need outside of the clinic to continue improving their motor function. So that has been sort of my soapbox of the last couple of years.
Okay, Lauren, why don't you talk about how you got into OT and where you're at today?
Yeah, so I am Lauren Souders, just to not be confused with Lauren Sheehan. I graduated from St. Louis University, and I always wanted to go into neuro because I felt like there was a lot of unmet need and direction where how do we treat these patients. And so I began my clinicals there, where I ended up working at the Rehabilitation Institute of St. Louis in their outpatient department. And from there is really where I saw my really focus into neuro. And that's where I worked as a clinical research specialist at Washington University in their Department of Neurology.
Oh, wow.
And I also worked as an adjunct faculty at St. Louis University at my alma mater. And really my focus was, how do we make this better? What is there new and innovative out there that we can do to help our patients? And so back in 2012, I began consulting with a company called Neurolutions, who I currently work for as a clinical manager. So I've been with them for 7 years, and really just trying to answer that question of what can we do that works for our neuro population.
Oh, that's why this topic is so great, because it's obviously the brain is amazing, right? Like, and there's just all this research out here. And so I'm kind of excited to kind of, dig into it. And so we always kind of look at about repetition and intensity, and that's obviously what we're going to be talking about. But how does that impact, the results for our patients that have had a stroke?
So, early on in stroke recovery, folks have a window that is, and I'm sure most OTs have heard the term spontaneous recovery. And it's really where the brain is primed from kind of a chemical standpoint, as well as neuroplasticity. The connections of the brain are really in that prime time for rewiring. The tricky part, of course, and we'll talk a fair amount about this, is just the challenges with how that prime time for brain recovery doesn't quite fit with how the neuro rehab landscape is primarily the inpatient side, right? So, you've got someone who really has the best opportunity to kind of get things reconnected, to avoid things like learned non-use, but then the system doesn't necessarily support them having a high intensity program focused on upper extremity recovery at that time period. It's usually not until much later that there's, even that switch of focus to hand and arm training after stroke. So we're up against a challenging system. The inpatient setting, of course, is really function focused, as it should be in a lot of ways. But a lot of the folks that I've worked with over the years on outpatient, and people that we continue to see on the technology side, the story is almost always the same, which is, they told me it would get better later. They told me not to worry about it now because it's the last to come back. And that's just not how we approach anything else in our practice. And so just trying to really figure out, as a technology company, but also as OTs, how do we infuse more intensity and repetition earlier on in the rehab process, and take, really give the onus to the patient, but give them the tools that they need in order to increase intensity and repetition in that early time period, as well as, when we're seeing them in outpatient or home health, or even in a skilled nursing facility. What we're doing in our sessions is just not enough in terms of repetition. So how can we pass that along to increase more kind of organic repetition throughout the day? So that's kind of setting the stage for the big issue that we're encountering and trying to, the problem that we're attempting to tackle.
Yeah. And just to kind of add to that, at the Rehab Institute where I had worked, this is Lauren Souders, by the way, Catherine Lang at Washington University did do a study where we all discussed that we know we need to work on motor recovery a lot earlier than what's notionally done right now. And so even with the focus of the therapist, okay, now we have time, let's do some upper extremity motor recovery. They conducted a study where they were counting how many repetitions are on average done on the inpatient side, with that focus of let's get the reps in. And the study showed that only 32 reps or less were provided for upper extremity motor rehab per day. So that's greatly falling short, which we'll discuss a little bit more later on. But just to kind of set that stage that even when we do try, it's still an uphill challenge.
Yeah. And like you said, we'll kind of dig into that a little bit more. But, it's like you were saying earlier about how you have the constraints of the system. It's like you kind of like we ideally know what we should be doing, and then like how that actually looks are two completely different things sometimes in a lot of different ways. But I mean, so it'll be good to kind of like look into like what are some things that we can do about that. So, we always also talk about like the research and supporting like task-based practice, right? So we need to integrate that, and because the research supports that. But how do we do this clinically? Because like you're saying, in inpatient especially, it's not, we have to do compensatory things, and you have such a short amount of time. But how do we integrate some of this task-based practice into our everyday practice?
Do you want to field that, Lauren, to start with?
Well, I think, we should probably just take a step back and talk a little bit about task-based practice and
good idea.
That, really functional tasks is what really drives that neuroplasticity, especially in those first 6 months. And completing tasks that are familiar to your patient in a client-centered way is really the way to kind of start facilitating their motivation. But in all, you pick up
That's
on
right.
me.
I can jump in. Task-based practice is really what we already do as OTs. It's using the meaning that a patient derives from the activities that are important to them, and really putting some structure around it. So 70% of task-based practice as it relates to neurorehab is actually focused on the task itself. So trying to understand what's meaningful, what the patient wants to be able to return to, and then using sort of shaping exercises to figure out what components of those tasks can the patient successfully do with their affected limb. How can it be worked again, more organically into their routine? And I think that that's the big disconnect when, therapists are focused on the patient that they're seeing in the clinic for that time period, but particularly for outpatient, which again, as we mentioned, is the first time that we're really honing in on upper extremity function. There are far fewer hours that are happening outside the clinic. And even in the inpatient setting, an OT might be seeing a patient an hour a day, but there are a lot of other hours of opportunity for practice. And I think, in all scenarios, a lot of time is wasted by the patient really not having direction in terms of how to incorporate that limb into their everyday routine. Because if we're only seeing 32 repetitions on average in inpatient therapy, how many times can we get the patient engaged in things that they're doing as they're eating meals or using the restroom, or, moving things on their tray, or adjusting their arm as it falls off their lap? There are just a lot of things that I think, have responsibility to tune patients into in terms of what they can do with that side, and then set the expectation that in order for them to see improvement, there has to be that inclusion of their, extremity into their everyday routine. So 70% of task-based practice is focused on those functional goals. And then 30% is really focused on kind of the components around using the upper extremity functionally. So that might be strength or sensory tasks. So kind of the supporting elements of what might be missing in terms of what's keeping them from improved function. And then we're looking at the environment as well, and the idea behind task-based practice is enhancing learning transferability. So really trying to figure out how to help patients generalize and transfer what they're learning in therapy or what they see that they can do into their routine, and really logging that activity. So logging it from both how often did I use that hand and arm in my daily task? Maybe there are 3 or 4 activities that have been set as an expectation for homework. Daily you're attempting to use your hand and arm to open drawers, open doors, hold, an item of food or a container while you open it. And then, we're setting the expectation of how often, and then the patient is giving feedback on how well they did. So it's really just giving an opportunity for practice in the clinic, transferring those activities to the home environment, and setting the expectation that every time that is attempted, the use of, their affected side is what should lead the way. And it's really regularly checking back in with folks to make sure that that practice is happening.
Yeah, I think the biggest piece is sometimes the therapists have so much on their plate, they're not sure kind of where to go. But I think a good place to focus is always educating your patient on this task-based practice and really setting the expectation of, this is the evidence and this is what you need to do. And a lot of the times, as Lauren was saying, just having them account for how often they're using their arm or using the motor activity log, if it's appropriate for that patient, just to kind of keep it on radar so that they always are kind of cognizant that they need to be using this arm, even if it's not perfect or even if it is with your other arm, but to always incorporate it as much as possible.
You guys brought up a lot of really good points, is really just like educating them and that this is part of it and how important it is. Because I think sometimes what happens is, from my experience anyway, we will say like, oh yeah, you need to be integrating it into your daily life or using it as a, trying to use it more. So we'll say things like, oh, when you're eating, make sure maybe you can use that hand to stabilize your bowl. But like, I don't think necessarily it's always the emphasis in talking about the research and why it needs to be done in order to have some of those gains.
Right.
Do you know what I'm saying?
Yeah.
Like, I don't feel like always it's emphasized as much as it should be. It's kind of more like but having those expectations, like you're saying, or having an activity log is a really good idea, because then, they can keep track and then they see how much or how little they are actually using it. And it's that, that feedback and responsibility and accountability a bit that I think does definitely help.
Yeah. And I think, another thing is when you're educating your patients, whether inpatient or outpatient, there's a lot going on in their lives, in their caregivers' lives. Yeah. And I think we just have to remember to really spell it out for them and not just say something like, well, yes, just try to incorporate your arm, but really have it written out, have a plan.
Right.
And I think that's going to help facilitate the type of reorganization that we're looking for.
Well, and I mean, I just kind of piggybacking on that is just like what that actually looks like, because I also think that they don't always know, like I said, spelling it out. Like, these are examples of ways you can do it, because it's not natural and it's not easy for them to do anyway. And so it's like really just laying down the foundation of what exactly they should do. Because to us, it seems really obvious, but it's not it's a whole new experience for them.
Yeah, it's a very new world
to try to, yeah. And there's just, like you said, there's so much going on. There's so many challenges and so many different avenues of their life. And so it's like making it as easy and clear what they need to be doing. But yeah, task-based practice, what is the current research saying about this? Or not even just, task-based practice, but even things like, what are some other approaches to neurorehab that's out there that, we should be looking at and incorporating?
This is an oldie study, but a goodie. In 2006, the famous Excite trial. Granted, as a disclaimer, the inclusion criteria was fairly a higher level of hemiparesis. However, they incorporated the constraint-induced movement therapy and had the motor activity logs. That was the largest gains I've seen on motor recovery with their primary outcome measure of the Wolf Motor Function Test. And when they actually assessed the durability of those motor results, 1 year later, they still had good motor movement. So again, they did start this kind of early on. So there is a possibility of that spontaneous recovery. But for the most part, they saw huge gains. That was the largest gains I've seen probably in a trial. And they used the motor activity log, and it was a very intense task-based, program. And a lot of that is what I tried to take when I started in the clinic around 2009, 2010, to really focus on that kind of that force use task-based practice if it was appropriate for them. So.
Mm-hmm. Like those, like a modified or a constraint-induced type of thing. Is that what you're talking about?
Exactly.
Like a forced use kind
and
of
then
thing
with
like
the
that.
accountability with the motor activity log to be used at home. And and the only difficulty with that is that it is a smaller percentage of the stroke population because they do have to have some active movement in that arm. So the next question is, what do you do when you don't have a patient that might be appropriate for a constraint protocol? And that's where that blend of task-oriented practice comes in. And I think we can modify that motor activity log to really facilitate to that patient hopefully in less than 6 months post-stroke to really drive that neural relearning.
Well, what happens? I mean, what does it say about like if that doesn't happen? Like, of course, ideally we want to do it early, we want to do it intense, right? But what happens about like if it's you see someone an outpatient and they're post a year? Does the repetition and the intensity still directly apply?
This is Lauren Sheehan. Once we get past kind of the window of, where we would see the most spontaneous recovery, then the studies, and we can definitely send you a bunch of resources for your listeners because there are some really big time trials that if you are in neuro-based practice and aren't familiar, they're just worth a read, like the Excite trial that Lauren mentioned. But really, after that 6-month window, when someone's considered to be kind of in the chronic phase of stroke recovery, that's when intensity is most important, really. That's where we see the differentiation of when patients do improve from a functional standpoint. At that level, it's based on really fairly high intensity. And Lauren and I just did a pretty thorough review of literature for some work that we've been doing with Neurolutions. And, there's still an opportunity for patients to make improvements at that chronic phase, but it requires far more than we're doing in the clinic. One of the resources that we're familiar with, and I've heard this literature and evidence come out at conferences in the recent past, but there's this, we're still kind of trying to put the exact pin on the amount of intensity that's needed. We're kind of missing the mark in some of the studies. So we're not seeing change, or, we may not have gotten to the threshold of intensity that's needed. But one of the interesting statistics, one of the interesting pieces in literature is that 17 hours a week of basically, upper extremity therapy over a 10-week period is considered kind of a threshold, that we wouldn't really want to do much less than that in order to see motor gains. So 17 hours a week over 10 weeks, if we're seeing someone in clinic an hour or two a week, we're just really missing the mark for that transfer. For them to get to the level of intensity that's needed. And, it's not the only intervention, but technology is one way to increase intensity, increase the number of repetitions that can be completed in a home-based environment. Because unless you're going to a CIMT camp or another really focused and very structured, intense intervention, it's hard for people to get that level of interaction and, initiation of using their upper extremity that we're seeing is needed for motor recovery.
Right. And I think,
well, I mean, that's crazy. I mean, because it is like 3 hours a day
at minimum. Yeah.
About
really. Yeah. So I think with the accountability of transferring this intense program at home, it's really hard in an outpatient clinic. And I think every clinician would agree, you give a home exercise program, we don't know what they're doing. We don't know how they're doing it or if they're doing it at all. And I think where possibly home-based technologies can really assist with that is that you can provide, hopefully, that oversight and accountability where they know the therapist is going to be looking to see, what are you doing? How many reps are you doing? Did you have any issues, to really drive the intensity of their motor program? So I think there is a place for home-based technologies to really drive this.
And there's some interesting pieces of technology, Mandy, that you you and the listeners might not be aware of. We sort of live and breathe it every day. So I feel like we have an idea of what's going on out in the world of technology. But there are some cool repetition counters now. Looks like a standard wristwatch, but would be something that patients would wear to actually measure the repetitions of the use of their limb. So, think about like a pedometer, or when Fitbit started to gain popularity, just that kind of target of trying to hit a certain number of repetitions in order to, give that goal kind of a place to land for patients and provide some motivation. And most of the technologies that are out there either have a repetition count, or, there's some way that they're meeting goals within the system, being able to track their progress, whether it's something like our device, which isn't available yet in the market, or, other devices that are out there that allow a patient to really get engaged in their therapy at home.
Yeah, and I think that piece, really that feedback, and the feedback really drives a compliant program. So having feedback for the patient of, this is how many reps you're doing and you've done more and you did them quicker, or I just think that provides a lot of, it keeps them engaged. And that's the biggest piece, is keeping your patient engaged to really drive what needs to be done. Because it is an intense program, and it is tough, especially when you are trying to get your life back and then you're focusing on such heavy rehab. I think sometimes the therapists also, we need to think about how it is in their shoes and how can they fit this intense program in their daily lives that have changed so much.
Is there any way, if, we talk about obviously like technology, because I think it's the easiest way, like what are some other, is there any other ways to kind of, I guess you guys did talk about like an activity log type of thing. Is there anything else that you guys have kind of found through the years that can help them, be able to track that, or, you know what I'm saying? Like, it's just like, because we don't all have access to the technology necessarily, or, there's all those different barriers of, income or renting and all these different things. If they have that access, I think that is a awesome way to go. But is there any more low tech?
Still a little
lower
techy,
tech,
but there are applications that are more, as I've seen, they're more ADL based, but it's, a checklist to help with initiation of tasks, and you can add notes. And then also there's a lot of programs that look at just home exercise programs on an app base, and then, the therapist can kind of check in. So there is some low tech ways. It's just the actual technology or the wearable technology isn't there, but, an application based support is. So,
yeah. How about measuring the progress, or like, documenting how that is? Because I would say, I remember, that was always one of my challenges, especially when I first kind of started out in OT. It's like, you can see those tiny bits of progress in your patients, but then it'd be sometimes hard to find a standardized test or standardized outcome that'll actually capture that. And then you're like, okay, well, I see it. I can't figure out how to, assess it. And then like actually documenting it is sometimes like those challenges, because they may not be able to like change in like a FIM score. Like they're not, they're not going from, independent or like a mod assist dressing to min assist dressing. It's not that, but you can see the progress. And I think that's also very applicable for like an upper extremity. So what do you have any suggestions on what kinds of like assessments kind of can capture
and
some
again,
of those small
what's tough in this
improvements?
population is everybody presents differently. But for the most part, the best kind of
Definitely.
go-to stroke assessments for upper extremity are the Fugl Meyer, as well as the Action Research Arm Test.
Mm-hmm.
And Lauren and I have been diving in and using the Arm Motor Ability Test, which is a function-based assessment just to kind of capture these small kind of bilateral functional movements. Yeah.
That's a really good one. We'll send you the
I've never
resources,
used that one,
Mandy.
so that's a good one to know.
It's one that I hadn't been aware of in the clinic, but what it does do is it really speaks to quality of movement, and I think that that's where we get lost in terms of trying to determine and document function that we see, just like you said, with our own eyes, and the patient can report it, but trying to actually put a sensitive enough measure to it. That would be my other recommendation, is really just choosing a measure. What are you trying to measure? What are we wanting to look at? Is it, are you looking for something that is more function focused? Is it quality of movement? Is it more fine motor? Is it sort of gross motricity? The other thing that I think is really interesting, and I think I was in this camp as well, but I think sometimes because standardized assessments can be daunting in their full extent, therapists don't use it at all. And, using pieces of a standardized assessment in a repeatable way is just as useful if you're going to attempt to insert some standardized sensitive measure. You don't have to do the whole thing. It's better than not doing it at all. So, again, really being cognizant of what you're wanting to measure, and then maybe choosing a couple of little pieces of standardized assessments that look at a variety of kind of the bigger picture of function, from a gross motor, more fine movement, and quality of movement.
Yeah. And aside from using assessments, if it's a very, a very, very tiny improvement that you notice that's huge, let's say I'll use, just index finger, you're just doing some finger extension. You're seeing a little flicker of finger extension that you've never seen. It's really important at baseline to just document what you saw, obviously, that there was no octave extension. But I think just always thinking of quantifying, or, let's say they were able to lift that finger 3 times, and then you can quantify that and then relate it as it relates to facilitating upper extremity function, or, improve motor control for subsequent function. And it's how you really explain why you're doing what you're doing. And just always thinking kind of in the little world of, how can I quantify this? Can I time it? Can I count it? Can I measure it? Aside from just those standardized tests as well.
Yeah. And those are good tips, because I think that is what happens. Like you see those little things and you're trying to, justify services or continued, and you're in the chronic stage and it's a lot slower, right? The progress is a lot slower. And those little things where you can actually also show your patient that look at our documentation is essentially, like 6 months ago, we couldn't do this and now we're at here, even if it's just tiny things, because it's hard for them too. I mean, it's just hard for them if the progress is slow. But I think, like you said, really kind of refocusing, we need to refocus on, the repetition and the intensity and where they're at to help with some of those gains. So, and also kind of just looking at like, how can we progress? How can we progress the intensity, or how can we progress? Exactly. It's just about like the shaping, right? And the task. And so how do we grade it? How do we shape the task so we can, challenge them a little bit more? And I think some of those are the things that are the challenges, I guess, of the, quote, everyday clinician.
Yeah. And I also think it's important, again, to always let your patients know what to expect. And I think I've said almost to every patient I've seen is, obviously they want this linear effect, like a broken bone. They break a bone and it heals. And I just always explain it's a stepping. It's a slow upward step, and you'll take an upward step and you may even go back 1 or 2 steps. but then you're going to hit a peak and you're going to go up again. And just to kind of expect that you're going to have some highs and lows, and it's not going to just heal biomechanically like a broken bone. But it really it takes a persistent focus. And I think when I've said that, and patients sometimes they don't think they're doing as well as they were the week prior, not to stress out about it. And that is something that I would expect to see, kind of that, up one step, down two, up one at times as well. So I think you're right. It can be a slow process. And our folks in the chronic stage really need that support. And again, I think that's where we have challenges in the chronic phase with insurance to clinics and how they're set up. It's difficult.
Well, and the motivation. I mean, they've been dealing with it for such a period of time, a lot of, often. And it's just like they want it. It's just hard to find that motivation sometimes. And so even when you're, I don't know, as a clinician, like digging in and saying like, what's meaningful to you and what do we need to do? But they feel like it's just like in this stagnant stage. But I think as, the research is supporting that we do need to be super intense and repetitive, even in that chronic stage, like you guys were saying. So, just reiterating that when they're having a hard time,
and there can be significant gains even on those standardized motivation in the chronic phase. But, and there's a lot of variables to why, and people may think that, but intense programs in the chronic phase is absolutely a must, and gains are being seen. And I know the common notion is, you're not going to make as many gains after 6 months post-stroke. Clinicians hear that all the time. I would disagree with that, just based off of studies and what I've seen in person. And I just think that people need to focus. A lot can change 6 months after stroke, 1 year after stroke, and even more.
Yeah, I mean, this is back when I was a student, so that kind of, ages me a bit. But even back then, it's kind of like when TAUB and all the, the modified and the constraint-induced therapy stuff was kind of coming out. And I was doing an internship at a facility where they had like a really intense outpatient, like a modified constraint-induced therapy program. And, we did the whole, like, take the video of, functional tasks and their range of motion and all that stuff prior to. And we had them, they were there, I think 8 hours, 8 patients, 8 hours. And they did the whole program, and we would work on shaping and doing the whole thing. And I actually honestly can't remember how long the outpatient program is, but as like with the research, it's, they have to fit a certain criteria, right? They have to be able to have so much movement and things like that. But the gain, because all these people were in chronic stage, years out, and the gains that they made just through that was so, it just kind of solidified that exactly what you were saying, that you can make a lot of gains if you put into practice some of those some of that repetition and intensity. But it's just a bit, so that's why it's like the technology thing, I think, is kind of a cool progress in our profession, that we can utilize some of those things to help our patients. So it's exciting. I like it. So what could you give some examples of, like, maybe if you were doing a task-oriented treatment session with a client?
Example. I had a patient who he loved carpentry, he loved fixing things. So that's when I would find something in the clinic that needed to be repaired, because we always had something that needed to be fixed. But I've had it where, and granted, it took a lot of support, but this person wanted to be able to hang up pictures again. So we actually, bilateral upper extremity kind of integrated together with the support as needed. I had some hand over hand assistance just to hammer a nail back in the wall, and then be able to, with both hands, to pick up a picture frame and kind of motor plan and coordinate where that needed to go and hang it. He didn't think he would ever be able to do that again. And yet that might seem so small in our eyes, but it's not. Mm-hmm. And it's something huge for that patient, that they then thought, well, with the help of, my wife, I would be able to do this when I got home. And so it's things like that. It could be things as simple as, cleaning off a kitchen counter, being able to transfer items into a sink. It's any type of functional involvement, meaningful and everyday tasks that you would just overlook and not even think of. So, that's kind of one way you can look at task-oriented practice.
And the breakdown might be really, really small. I mean, one of the pieces of task-oriented practice is that we're considering, the patient factors as well as the environment. So maybe the person really has very little, shoulder activation, for example. Maybe they're just getting some emerging grasp, looking at kind of the motor components. Also discussing, obviously, with the patient contextually what they want to be able to do, and then trying to put it together. So, for example, if someone had, maybe some emerging shoulder flexion and a little bit of grasp emerging, and they loved to be in the kitchen. I mean, something as simple as wiping, like Lauren mentioned, or putting, spices into the drawer or putting away silverware, just something to get them moving in that contextual environment, using the activation that they have and the motivation of the task. Maybe it's just opening and closing the drawers as they're working in the kitchen, but every time that they do it with their affected side. And then it's also, building that up. So taking transferable tasks, or maybe even something that's similar but meaningful, and trying to, again, figure out what we can apply based on the activation that they do have, pick up the intensity or the challenge a little bit, and then continually try and incorporate that upper extremity into more challenging activities. I think that the really tricky part is that sometimes, and I do think it's about setting the expectation. Patients come to therapy sometimes to be fixed, and just really the understanding. And I think, caregivers or people that are important in their lives need to be on board as well. Like, this is kind of where you come to get the prescription of what you do at home. And then we're, team working together on how to get you further along in the process. But I think just really hitting home that the time in clinic is just the start. It's really just scraping the surface and, trying to figure out how to incorporate that limb into everyday activities, which is not easy to do by any means. Some of the other things that we're seeing happen kind of in the marketplace or in the clinic is some facilities are doing like an intensive neuro gym type program where patients can access equipment that might be available, like technologies, robotics, exoskeletons, different types of high ticket item technology in a kind of circuit type fashion where they pay maybe a monthly amount. And this is usually after they're either done with their formal therapy or to supplement it. And they go in and can spend time in the clinical setting using these pieces of equipment after they've been trained so that they can continue the intensity of their program. Maybe they make continued gains and then they come back for another round of therapy. So there are some really creative solutions that are happening in the outpatient settings and centers. And if that's not something that is offered, at a therapist's location, even if you have pretty low tech items, something like a neuro gym is really a good way to keep patients connected and give them a place to go to do their therapy in community with other, stroke survivors.
Yeah. And something else I've seen, it's kind of new. I haven't seen it in a lot of clinics, but I have seen it more and more occurring lately, which is it's kind of that neuro gym concept that Lauren was just talking about, but it's kind of just this robotics program that is kind of supervised by more of a therapy technician. And they do that on the side, either before or after their formal therapy. And so they really get intensity of focus with the therapist, and then they can go get intensity of reps in the robotics area before or after as well. So I'm seeing more and more of that pop up in outpatient clinics recently.
And I think, like letting them be able to do that in a somewhat structured environment, I think would be really helpful for some people versus feeling like you're supposed to do this at home. It's kind of like when I go to the gym, like they're like, just exercise at home. And I'm like, I'm trying, but I'm not very consistent. But then I go to a gym. You know what I'm saying? Like you have that somewhat of a structure and you're like, you have to be somewhere at a certain time and you have your support system and you like hang out with your friends and like it becomes like a community. And you're doing what's good for, almost, your recovery.
Kind of the notion we always want our patients to have is that when you come to outpatient, we're teaching you to be your own therapist. Really? I mean, we're giving you the tools and information to be your own therapist. And having those rehab gyms, I think really helps. Again, and you actually hit the nail on the head with community. When they have a community and they can talk to people about it, it really keeps them engaged in a way that I think is more beneficial than if you don't have that community. So,
well, and they're, I always think about those things where it's like they get to, converse with and relate to people that have went through a very similar experience. That, we see a lot of patients that have gone through their experience, but it's not the same as relating with someone or talking to someone that has actually been through it. It's two different things. So I can see how that whole thing just kind of creates that sense of community. So that's really neat. I love that. What would you guys say are some like key takeaways? If you have an OT clinician out there, we talked about research and we talked about repetition stuff. What would you say are some like key takeaways that they can take from this conversation and then kind of just
2 points here. One is the expectations of your patient
clinical practice.
They want to know what to do, and I think we really need to detail and spell it out for what exactly we want them to do to the most simple level, and setting that expectation and really telling them that the work that has to be kind of provided to get these motor gains, it's a lot, and we just need to set that bar high for them to gain that intensity. And for clinicians, as Lauren said earlier, progress is important. We have to document what's going on. And in using, again, the time of the clinic may not be conducive for completing all of these, standardized assessments, but pick a couple subtests and that you think might capture what movements that you're addressing and just do a couple of them and get your hands, dirty a little bit with the subtests, and then you'll hopefully feel more comfortable as well. But again, I think it's really setting up your patient to give them the expectations, accountability, motor activity logs, and just really explain to them how much effort it's going to take. And it's a lot, and that you're there to help them and support them.
No, yep. Those are some good ways. Cause I like the, having clear expectations too, because I don't even, like sometimes you feel like you are, but like, are you explaining what you exactly want them to do? So I think that's some great takeaways. Gosh, guys, thank you so much for
I would encourage
sharing your knowledge and passion and research on this topic.
Access to the latest research. And we can send these to you, Mandy, for the show notes. But one of the ones that I really have always come back to is the evidence-based stroke rehab. It's out of Canada, and it's basically a deep dive into the literature. There's a whole chapter on motor recovery and basically a look at all of the different interventions, what the literature says, what the support is, whether or not the verdict is still out on some of the interventions that we're seeing used in clinics. And then the Shirley Abilitylab, which is formerly the Rehab Institute of Chicago, has an awesome rehabilitation measures sort of catalog online. And again, looking at ways to incorporate just small components of those assessments might really be, good opportunities to capture the changes that we're seeing, but that we sometimes don't have the sort of language or rating or, objectivity behind. So we'll send some additional resources your way. And we're just excited to continue the conversation and to support therapists that are seeing this population because we know that it's a challenge. But I think we're all trying to figure out how to solve, making it easier and more streamlined to see improvement in this chronic stroke population. So keep fighting the good fight.
Do it. So I'll add those, the evidence-based stroke rehab, Shirley Ryan, Abilitylab. I'll put in the links to those assessments you guys were talking about, the Fugl Meyer, the ARAT, the AMAT, and some research, and just kind of try to make it a little comprehensive resource for everyone after they've listened to this conversation today. So thank you, Lauren and Lauren, for joining me today. All right, everyone. Thanks for listening, and until next time.
Do you feel like you're navigating the OT world without a map? Not feeling confident or competent in your day-to-day treatments and struggling to apply your knowledge clinically? Then be sure to check out the Seniors Flourish Learning Lab membership. It has all the treatment ideas, patient handouts, clinical resources, community support, and mentorship you need to succeed. Join today at seniorsflourish.com/learninglab.